Dirk's going to talk about adnex. I'm going to have a quick word about physiological cysts and then talk about IOTA benign descriptors, which we think are the first things you should use when trying to classify a mass. And after, if the descriptors don't apply, then as Dirk will describe later, we can use the IOTA adnex model. Now, I love this slide because this tells you everything you need to know about ultrasound, actually, but certainly classifying cysts. And you can see here that, fundamentally, if you can't tell the difference between a blueberry muffin and a chihuahua, then you may run into trouble when you're eating your breakfast. And whilst this might seem a rather silly slide, actually, when you look, these dogs and the muffins have actually very similar features. And if we went to an AI algorithm, we'd probably find that AI would find these quite difficult to discriminate between. But of course, because you are humans and you're very used to seeing faces, you've got no problem doing this. And that's because of familiarity and the fact that because of the way cognitive theory works, if you like, that you don't have to even think about it, you get the answer right. And that's actually the case with some ovarian masses. Because when we look at ovarian masses, some we can recognize with pattern recognition, some we can use simple descriptors to get the right diagnosis, in others we need more help. So, a number of masses you will see will in fact be physiological. These are all hemorrhagic cysts, and they're probably going to resolve in about 6 to 8 weeks if you just give them time to do so. And so when we're talking about the application of descriptors, as we can see here, or when we're evaluating any other masses, we're talking about persistent masses that have been given a chance to resolve. Excuse me. So a number of cysts, particularly in young women, will be physiological. I'm going to discuss easy benign descriptors, which will probably be able to classify about 30% of the masses that come through your daily practice. And then Dirk is going to discuss how you might approach the rest of the masses where we can apply the IOTA adnex model as a two-step way of approaching the classification of ovarian masses, or you can use adnex for all masses. But we advocate repeating scans to rule out physiological cysts, application of benign descriptors, and then the use of adnex. But first, let's look at these pathologies that actually don't need descriptors or models. And by that, I mean hemorrhagic cysts. But I've also thought, because I'm speaking here, just to have a mention of a couple of other causes of acute pain in young women, torsion and an abscess. Although I'd like to be clear, these two cases are not relevant to benign descriptors or adnex. Hemorrhagic cysts are often quite easy and straightforward, but they can look a bit strange, particularly when, as you can see in all of these 4 examples, this one down here on the bottom right is probably the most classic, with these cobweb appearance, with ground glass content, classically a hemorrhagic cyst with some retracting clot. And this is a very similar looking cyst here. You can see not quite so obvious in terms of the cobweb threads, but you I think get the pattern. But some will look a little bit strange where the retracting clot will mimic solid tissue. And you can see here where we put the color Doppler gauge with a PRF of 0.3, there's no flow there. And so you can see clearly that this is not solid tissue. But of course, the way to also look at this is to use the dynamic nature of ultrasound. And very often when you have this sort of appearance of the ovary and you prod the ovary, you'll find that the contents are jelly-like and it'll wobble, as you can see here in this very short video. And so hemorrhagic cysts should be pretty straightforward to get right. But sometimes they will cause clinical problems. And you can see here how this lady has had, in fact, a collapsed hemorrhagic cyst, but a large amount of blood in her pelvis. You can see here blood above the fundus of the uterus. And when you look in Morrison's pouch between the liver and the kidney, she's got blood throughout the pelvis and abdomen. And this lady was taking anticoagulants. And so even though these are generally things that settle down, on occasion they will cause clinical problems. And you can see here we have the cause of the issue in this particular case. Just to say a quick word about torsion, because we're not speaking about this, I think, elsewhere in the Ultrasound Essentials program. Torsion generally associated with an enlarged ovary, often misplaced above the uterus, sometimes actually even easier to image using an abdominal scan. You get this lack of architecture and sort of edematous appearance, often with peripherally placed follicles, and a sort of blurring of the internal architecture and the presence of the so-called whirlpool sign, although I don't think that's necessarily something that you need to be looking at too hard, and you often get some free fluid around the ovary as well. So an important thing to diagnose. And also pelvic abscesses. As you can see, we know these are irregular. We're going to talk about this later, but the reason I wanted to include abscesses is just a plea to consider aspiration. Often these are difficult to manage surgically if you need to drain them. However, Seth Granberg has shown in a large series actually of over 300 cases some years ago now, and you can see here how you had a needle has been put into the abscess and aspirated under ultrasound guidance. You can successfully resolve the abscess in a number of cases, and you can see very few of them needing more than one aspiration, and you can see that these are often quite large cysts. You can see in his case here, most of them were resolved with just one aspiration, some needing two. And so this is a simple ultrasound-based approach to managing this condition. However, moving on, I'm just going to talk about these benign descriptors. Now, these were developed by the IOTA group because most masses, or some masses at least, do not need mathematical models to figure out what they are. And the benign easy descriptors were essentially designed to pick up what you might call unilocular cysts, often cystadenomas, mucinous cystadenomas, dermoid cysts, and endometriomas. And so if we look at what these are, there are 4 of them. You have unilocular tumors with a ground glass echogenicity less than 10 centimeters in a premenopausal woman, as you can see here, classic endometrioma. Unilocular mixed echogenicity and acoustic shadows less than 10 centimeters, again in a premenopausal woman. Classic dermoid cyst. And then you've got unilocular anechoic tumors less than 10 and remaining unilocular tumors, which may include, for example, scattered echoes, as you can see here, which will pick up some of these benign mucinous masses. So on this descriptor, this will hopefully pick up benign cystadenomas, and this a number of mucinous type tumors or others where the cyst content is not anechoic. So if you see a mass and it fits with these descriptors, then you can apply the benign descriptors as long as no other features are present. So if we look at them again, just to run through them with some different examples, and just to emphasize that the mass has to be less than 10 centimeters for benign descriptor 3 and benign descriptor 4. So benign descriptor 1, mainly endometriomas, 2, mainly dermoids, and then these 2 unilocular cysts, anechoic or not. So what about the results? What happens if you use these? Well, you can see this is IOTA 3 data published by Levika Ame some years ago now, over 3,500 masses. And you can see essentially that if you apply the descriptors and in these cases, the likelihood of you having the correct outcome is almost 100%. And so these are extremely good in terms of test performance, and you're also probably going to get the correct histology as well in most cases. In other words, if it looks like a classic dermoid, the descriptors apply, then it is going to be a dermoid, similarly with an endometrioma, and similarly with some of these unilocular cysts as well. So highly reassuring, and in this population, we could apply these descriptors in 30% of cases in a population where there's quite a high prevalence of malignancy. So in general, you're going to be able to figure out about 1/3 of the masses by applying benign descriptors. Just to look at some more data, this is a paper published relatively recently, which was about the 2-step strategy, which I think Dirk is going to talk about, where initially you apply the benign descriptors, which I've just described, and then to the residual masses, apply adnex. But let's just look at the performance of the benign descriptors on almost 1,800 masses. And you can see that when you had the benign descriptors and you could apply them, almost all of the masses were benign, whether it was benign descriptor 1, 2, 3, or 4. In all cases, 98 to almost 100%. And you can see here the likelihood, if you classify a mass as benign using the benign descriptors, you can see the likelihood of you making a mistake and there being a borderline tumor, is very low, 0.3, 0.1, 0.1, 0.1 for primary invasive, stage 1, 2 to 4, or metastatic tumors. So again, in this very large data set, you can see that the benign descriptors perform extremely well. So if you just look at a few examples, here we have an ovarian cyst, it's 27, it's unilocular, mixed content, there are acoustic shadows present, and in this case, the color score on the C125 are not particularly relevant. And so if we look at the benign descriptors, clearly this doesn't apply, but the bottom two don't apply, but this is unilocular mixed heterogeneity with acoustic shadows less than 10 centimeters. So you'll classify the mass as benign, probable dermoid cyst. Exactly the same situation here. Looks like a classic dermoid. It's unilocular, ground glass heterogeneity, it's less than 10 centimeters, and she's presenting clinically with pelvic pain. And once again, you can see clearly, if you look at these four options, this is unilocular, ground glass less than 10 in a premenopausal woman. Therefore, it's benign, and you'd think this is most likely endometrioma. So really, really straightforward, that allows you to get the diagnosis right in terms of benign or malignant in about a third of the cysts that walk in through your door. Clearly, a situation where the descriptors are not going to apply, I think it's important to show an example of that as well. You can see this is a multilocular solid lesion of the ovary. There's more than 3 papillations, and if you start trying to apply benign descriptors, none of these apply, as you can see quite clearly, and so we can't use them. So in this case, can't use the descriptors, we need to use something else, and as Dirk is going to argue in a moment, I believe that you should use the IOTA adnex model to classify this mass. So we will discuss in a moment what you should use, adnex alone to look at all masses, or the simple descriptors that I've just talked about, plus adnex, and I would suggest that you use the simple descriptors because it's really intuitive, and you can apply them to about 30% of masses and use adnex for the rest. And so I just want to draw your attention to the IOTA Group Facebook page, where a lot of information about our studies is hosted. So do come and join us as a community. And I'll just finish there and take any questions, but I think it may be the best thing is to hear what Dirk has to say, and then we can discuss the classification of ovarian masses in general terms later on. So thank you very much for listening, and I'll stop sharing and come back, as it were, to the main program.
Yep. No, thanks a lot, Tom, for enlightening presentation. I think we are building up to the malignant process, but the delegates, one of the delegates is interested to know, to say, how do you measure the third dimension from a presentation?
Oh, I think it was going back to Lille, wasn't it? I mean, essentially, whatever plane you're in, you turn the probe at 90 degrees. Now, obviously, it's not as simple as that because you rock the probe a little bit to get that third diameter. So it's classically, this is what you're measuring. You have these 3 planes, okay? These planes are the ones you're measuring. So you have to rotate from there to that way, so to get that other plane. So it's the third plane is how you do it, okay? There are a few other questions here, which I'll try and remember. I mean, looking through, quite a lot of questions coming through. which I'll try and speak about. I mean, they've done the third dimension, differentiating between a corpus luteum and a cyst. Well, I mean, it's not always that simple. I mean, you've got to say a cyst is just a fluid-filled area. But I would say that a corpus luteum classically, often most corpus lutea have a very classic appearance, almost with a double wall. They have classic ring of fire vascularity, and obviously they're not, generally they're not as large as what I would call a cyst. A cyst I tend to take as being becoming a cyst, if you like, when it's over 3 centimeters. Myself, though others people may differ in their opinion. Fresh blood and organized blood in a cyst. I mean, fresh blood usually looks completely ground glass, and once it becomes organized, as you can see in some of those pictures, it tends to retract a little bit and become more jelly-like. And so fresh blood, sometimes won't wobble when you prod it, but organized blood, as it retracts, will act like jelly, and so you'll be able to tell the difference. The ovarian torsion, I think I just talked about, just looking at these images. Often the ovary is increased in size. It's often displaced, sometimes even out of the pelvis. Often you get somewhat peripheral organization of the follicles. The architecture of the ovary is blurred. You will often get a bit of free fluid in the pelvis, and there's also the whirlpool sign of vascularity people quote. I haven't seen that often, but people quote. And I think it's very important also to listen to the patient and listen to the history as well. You're not scanning a patient in isolation. So that's quickly trying to go through the questions that have come up on the chat.
Yeah. No, thanks, Tom. I think your last keynote is correlating what the history, what you see on physical findings, and then what you see on the ultrasound. Then marry everything together to see if it's making any sense.
100%. You scan the patient. You don't do a scan. So the scan is part of the situation. People talk sometimes about pelvic abscess and or whatever. I mean, obviously, in a pelvic abscess, the clinical situation is often going to be different, in terms of the other parameters that you're looking at, and tenderness when you scan, and the general condition of the patient. So I think it's really important that you look at the whole picture and look at the patient as a whole, and see ultrasound as a tool, which is part of the assessment, especially in acute and emergency gynecology. It's very important.
Yeah. Thanks, Tom, and thanks to our delegate.